And let's start screening and okay. And start recording. That's perfect. Okay, do you see the screen?
اي نعم استاذ نشوفها.
تمام. Okay, بسم الله الرحمن الرحيم. السلام عليكم جميعا. Thank you for joining. Always newborn screening is an assessment is سهل ممتنع. People think it's easy, and most of my registrar in the hospital and the resident and the GPs usually caught in Ministry of Health complain because of they either wrong assessment or wrong documentation or use of inappropriate words. And sometimes they start to comment on obstetric, and they are not obstetricians, so they are always caught, and then they find liables, and they got either settlement by money or they got suspended license or whatever, and sometimes easy, such as word cyanosis and congestion, and you know, improper documentation and conflict of documentation between one resident and another. So today we're gonna show you how to assess a newborn and how to document that, and what you should say and what you should not say. بالعراقي يقولون كذب المخربط أحسن من صدق كذب المصفط أحسن من صدق المخربط. So you have to know how to write, and post-delivery notes are very important because it's a legal document. Most of them used by lawyers, and now maybe it's not in Iraq anymore, but it will start because there is medical claim lawyers, and they have agent in the hospital, and they call any patients if there is any medical error, and they will ask for compensation, especially private hospitals. So you have to be very careful what to say and what to document. So when we say newborn assessment, we're talking about assessing the newborn babies within 24 hours of life. We have to check for any abnormality that might alter the course of the newborn baby. We have to check for medical conditions, anomalies. We'll look for birth trauma, jaundice, cardiorespiratory disorders. All these need to be screening according to the American Academy of Pediatrics. This assessment should include not only assessment, but you have to review the maternal, family, and prenatal history, and a complete examination. And the examination should include also screening. So you're screening a baby for certain things. So if you don't do red reflex, then you will be in a big trouble, because if the baby turned blind at 6 months, then all the expenses will be on you and the hospital. The baby has congenital developmental dysplasia of hip, or if the baby has corcutation of aorta, and so on, so forth. These are all, this depend. Now the examination depend on how long the baby stay in the hospital with their mom, 24, 48, or 72 hours, depend on the hospital, but we need examination within 24 hours and another examination before discharge. It's vital to review the pregnancy, labor, and delivery, including prenatal testing that's done by the obstetrician, and also including risk factors. I always say to the resident that it's always correct to start antibiotics, but it's always wrong to continue antibiotics if there is no need. So to start antibiotics, you should have risk factors plus symptom. Risk factors plus symptoms. Okay, you need to review past pregnancy, past death, past GPS, for example, anomalies. If there is a stillbirth or abortion, any genetic syndrome, consanguinity, and so on, these need to be documented and known. Mother and father medical and genetic histories, medical illnesses, SLE, diabetes, gestational or type 1 or type 2, fetal growth, and fetal growth also might lead to other complications. Somebody is sending text. I cannot answer the text because I'm okay. So, and also medications that have intrauterine effect or can be excreted in the milk. Now, there is a list of prenatal testing that I'm not going to go through, but the prenatal screening tests are routinely performed. Any abnormal finding indicate a medical condition that need verification. So in first visit, around 12 to 13 weeks of gestation, these are needed. APO, RH, rubella, syphilis, hepatitis B, hematocrit, urinalysis, chlamydia, Neisseria gonorrhea screen, HIV, hepatitis B, and hepatitis C. Selective screening for the diabetes or thyroid depend on the situation, and other infections are need to be screened. Screening test obtained later in pregnancy, not in the around 20 to 22 weeks. Maternal diabetes, GPS usually done at age of 34 weeks. Screening for birth defects such as Down syndrome, nuchal cord, nuchal rigidity, other signs of Downs, multiplex marker screening, fetal ultrasound, volume, heart, others. If mother are suspicious of any problem, need to be screened. HIV is vital to be done, hepatitis B, hepatitis C, and others. Now, at the baby, when baby deliver, need to know the event around the delivery. So what is the duration of labor, prolonged or precipitate? Is the membrane ruptured, and when? By hours. Is more than 12, more than 18 or less than 18 in bacterial infection, and it's more than or less than 4 hours in herpes. What is the mode of delivery? C-section, emergency, crush, elective, semi-elective, normal vaginal, or instrumental deliveries, vacuum, or forceps. What is the newborn condition? And when you mention, you have to decide baby is for NRP or for routine care. NRP, if the NRP question, which is the 3 questions, and if it's yes, then go for NRP, and if it's no, then you go for well baby assessment. So we will give you the NRP or newborn resuscitation at some point, but not now. When you resuscitate a baby, most of the doctors need to intubate and give surfactant. And how I define neonatologist is the doctor who can avoid intubation. That's a neonatologist, not to intubate. So there are many things that are more important than intubation. And intubation is least priority actually, is hypothermia, hypoglycemia. So your target is to control the body temperature and also start dextrose within 10 minutes of life, and CPAP within 2 minutes of life, and premature baby caffeine within 20 minutes of life. Because apneas are very important, and poor feeding. This is, sorry, this is a spelling error. Now, most of babies, they will say it's a term baby. Term means nothing, because 38 is term and 39 is term, 37 is term. 37 is totally different from the 30. 37 plus 1 is different from 37.6. So term and preterm is nothing, means nothing. I need a gestation. I need weeks and days. So this baby is 36 plus 5, this baby 37 plus 2. So you need weeks, and it's by date or by ultrasound. You need to make sure that these subjective terms are not acceptable in the court. You have to be very careful when you document these. So preterm, when you say preterm, any baby less than 37 completed week. Late preterms mean 34 to 36 plus 6. And term is 37 plus 7 to 38 plus 6. And there is early term and there is late term. Now remember that late preterm and early term are prone to hypoglycemia, need for support, intubation, need IV fluid, hyperbilirubinemia, need maybe antibiotics if there is risk factor. Now, risk factor of sepsis is very important to assess that. Now, maternal intrapartum temperature. For me, any temperature more than 38, if recorded twice, 2 hours apart, is a temperature. If it's one reading more than 38.5, then it's a temperature. Leaking 18 hours and more for bacteria and more 4 hours for herpes. If delivery is less than 37, okay, but not induced or not by section. When we say less than 37, we mean there is a spontaneous labor. Signs of chorioamnitis, whether fever or leukocytosis or tenderness or foul-smelling liquor, and positive GPS or group B streptococcus and not treated. So how we diagnose neonatal sepsis? Am I guy too fast or my pace is good?
Good, sir.
Okay. So neonatal sepsis, you should have risk factors and symptom to treat. If only risk factor, no treatment. Only symptom, there is no need for treatment. Okay. So once you have risk factors and symptom, you need to do sepsis workup. Now the risk factors are these: labor, mother in labor, labor pain, PROM more than 18 hours, maternal fever, leukocytosis, tenderness, GPS positive, urine or vaginal swab positive, previous neonatal sepsis, previous unknown cause of neonatal death, fetal distress, fetal growth retardation or restriction, and symptoms. So any symptom, prematurity is a symptom if the mother in labor, not prematurity induced by C-section or by induction of labor, RDS, poor activity, hypotonia. And there is nothing called floppy. This is floppy in infant. In newborn, we cannot use. This is a subjective term. It will put you in court in a problem. Vomiting, hypoglycemia, temperature instability, hypo, tachycardia, bradycardia, apnea, seizure, feeding intolerance. So when we say sepsis workup, we mean, and it's not septic workup. When we say septic workup, mean that our workup is septic, is dirty. People wrongly say septic workup. It's incorrect. It's sepsis workup. It's workup for sepsis. It's not septic workup. Septic workup mean our workup is dirty. So when we say sepsis workup, we mean CBC, culture, ampicillin, gentamicin for 36, 48 hours. If no report or culture negative, and then you should never use antibiotics without blood culture. Give me 1 minute, please. أيوة دكتور خالد باشا حبيبي. No, he said need a proper assessment. We will give Lasix. Okay. ماشي شكرا حبيبي. يلا إن شاء الله. Thank you. Okay. So we have risk factors or symptom and sign. So we don't have one of them. Then what we should do on monitoring. So these are the risk factors or symptoms. Then you do monitoring, which is CBC, vital signs every 6 hours, including temperature, respiratory rate, heart rate, blood pressure, maybe sugar, and 48 hours monitoring in the hospital. If symptom develop or if change anything, then we might need to start antibiotics. Okay, so you did sepsis workup. What else you need to do? If culture is positive, then treat accordingly. So treat, repeat every 48 hours, and treatment usually 6 to 17, 7 to 14 if gram positive. If gram negative, it's 14 to 21 days. If it's localized, and usually in the late onset sepsis, it's usually 14 to 21 days. And then send the baby home if you give 21, 7 or 14 plus last 48 hours culture negative. So you keep repeating the blood culture until you have 2 days culture negative, then you send home. Now, culture negative sepsis, and so you might give 5 days antibiotics, repeat after 48 hours, and then if for last 48 hours culture negative, then you send home. If you monitor the baby and you do vital signs and there is no sign symptom, you send the baby home. But if sign symptoms develop, then you do sepsis workup and then you divide according it's culture positive or culture negative. Any question?
العفو أستاذ، بالنسبة إذا طلع الكلتشر نيجاتيف sepsis, why we start antibiotic for 5 days?
If symptomatic.
If symptomatic.
Yes. And so there is something called yield of blood culture. You know, the possibility that the blood culture will be positive. So if you do one site blood culture, you need volume. So, and you have the volume should be 1 ml. The yield at 24 hours, so if the culture is negative at 24 hours, it means 60% yes, it's negative. If it's at 36 hours is negative, it's 76% is yes, negative. If it's at 48 hours negative, it's around 90% negative. If it's 72 hours, it's about 95%. Yes, if it's negative, yes, there might be possibility. So if you add symptom to it, if you add investigation to it, then the likelihood will be high. So there is something called. So even if it's culture negative, yes, sir.
العفو، اذا يعني احنا قلنا ما راح ندي انتيبايوتيك اذا الا عندنا لازم سيمتوم وياها الريسك فاكتور. يعني احنا راح
نعتمد. So you have symptom, and you have risk factors, but you didn't tell blood culture. Yes.
Negative نبدي انتيبايوتيك 5
أيام. Correct. Yes. So you have symptoms and risk factors. You did sepsis workup. Your culture came negative, but you have symptoms and risk factors. If it came positive, it's according. If symptom disappeared, then nothing need to be in. But if you have symptomatic, then yes, you need to continue antibiotics for 5 days, and your culture should be 48 hours negative. Okay?
تمام. شكرا.
Okay, so let's start with general examination. Do you guys have any question? Please ask questions. I will stop at 25 slides, so if you can ask me questions. Okay? Any question? Otherwise, I will ask questions. No question?
No question.
Okay, so the first examination can be in the resus room, can be in the nursery, can be in the NICU, or can be in the combined care with the mother. And it should be done within 24 hours. Should be warm and quiet place, and you should have good light and to be like LD, like a white light. So you observe general appearance, including his or her position and body movement, color, respiratory effort, and you do measurement, and you do individual examination of organs, and will be gone one by one. So how you define hypotonia in a newborn baby? What is hypotonia? Anybody knows? What is hypotonia in a newborn baby?
Hypotonia in the newborn baby is head lag.
Usually we cannot do head lag in the newborn babies. It's very difficult to be done. But before head lag, by observation.
Floppy position.
Position of leg.
So, okay. Avoid the word floppy. Floppy is a subjective term, means nothing in medicine. Okay. Anybody else?
Frog-like position.
It can be frog-like. What is frog-like position? So if I am a lawyer, you want to tell me frog-like position. What does that mean?
It's
the hand, the foot on the matrix. The hand and the foot on the matrix. The hand and the foot on the matrix. Good position. The hand and the feet off the matrix. The hand and the feet off the matrix. Good tone. Okay. And you can do axillary suspension. You can do ventral suspension, or you can do head lag positions. Usually we don't like it only in infant, but you can do them if it's still suspicious that it's hypotonia. So hypotonia, the hand and the foot on the matrix, the hand and the foot off the matrix, then it's a good tone. Any question? Okay. So the examination, you should select a manner, a systemic way. So you can say, I will start from head to toe, or from toe to head, or back and front, or I will do a system. So you select a system, and it's better all the hospital use all the system and the same documentation. So the following of the order is very important, especially if one does the she or he does the first exam, and another person, she or he does the discharge exam. So if you write in two different ways, and the handwriting, can somebody ask me how many pages I write when I did first exam? How many pages you think I will write to do a newborn exam? But most of the time I'm involved in a complicated babies, not like a normal baby. almost I write 2 to 4 pages of notes. If I am rushed, I will never write, because if it goes to the court, nobody will, not the hospital, not the patient queuing outside. Okay. So you need to system, and you need to make sure that you do the hip and the back and the screen and the spine. Okay. Hip examination, it has to be in supine and in the prone position. So examine the hip in 2 places, mostly observe. The date and time of examination should be recorded. It's always good to examine the baby or with their mothers or father. Remember that transitional murmurs due to open PDA. Remember to assess the gestation, whether by date or ultrasound, or use gestational assessment chart. Maturity is very important for the output and the expected complication, and also the rate of readmission. Your hand should be warm. You should be resting your hand, not intense, and you should not provide any stimulation. You need also to inspect for the sex, male or female, and whether the male and female organs are mature, any birth defect, fetal nutrition, respiratory effort, position of movement, color assessment. Okay, so hand and foot, very important to say what is exactly the defect. And I found always people confused between metatarsus adductus and talibis equinovarus and talibis equinovulgus. So varus, vulgus, adductus, abductus, these terms are very important. You need to know how to assess, how to draw lines, and even cavovarus and or varus. So all these calcaneovulgus, all these you need to know in details, and you need to understand, and you need to know what is the management and to whom you refer, and what is the consequences and what is the prognosis. You need also to see if there is a cleft lip and cleft palate. Is it unilateral? Is it bilateral? Is it hard? If it's a cleft lip and cleft palate, it's hard and soft. You need to know how to manage. You need to know the phases of feeding. So providing the seal, providing the negative pressure, then the positive pressure, then the oropharyngeal, then the pharyngeal, then esophageal, then lower esophageal phase. So these phases, and then you need to know the deglutition. What is deglutition? Anybody knows? What is the difference between swallowing and deglutition?
You mean the coordination of swallowing?
So here's advice for you, Taha, right?
The coordination of swallowing.
Dr. Taha.
نعم sir.
Yeah, here's an advice for you. You put it in your ears, never forget it. Okay? Never answer by question. Okay? So, sir, okay, you can say, can you clarify? I don't understand. Can you clarify? But you say, you mean, and then you give me, that's mean you want me to give you an answer. For the examiner, this is, you are trying to trick the examiner. So never answer by question. So do you know the answer, or you don't know the answer?
I don't know.
Okay. Anybody knows? What is the difference between deglutition and swallowing?
Okay. Doctor, deglutition, the action or process of swallowing.
Okay, and swallowing.
And sometimes we call deglutition in scientific context the process in a human or animal body that allows substance to pass from mouth to pharynx into esophagus while shutting glottis.
No, wrong. Taha answered it, but he was not sure. Deglutition is a coordination of swallowing and respiration, while swallowing is movement of esophagus. That's the difference. Deglutition is a coordinated. That's why sucking start at age of 31 weeks, swallowing start about 32 weeks, and deglutition about 33, 34 weeks. And that's why below 33, 30, you always need NG feeding. Clear?
Below what age? 32?
About 30 weeks, you start to have sucking. About 32 weeks, you have to start to have sucking and swallowing.
Yes.
About 33, 34, you get deglutition.
Okay.
Clear?
Yeah, I also said it's passage of the food from mouth to pharynx to esophagus while closing the epiglottis. You know, I think I said it in different term.
No, you didn't say it correctly. You think you're saying it correctly. Either you are Ahmed, but you can say I am 190 centimeter tall. My weight is 60 kilometer, and I am a male, not a female, and I live in Rumadi, and I go to medical school, and I'm in board, right? So by the end you are Ahmed, but you didn't say you are Ahmed, right?
Okay.
Yeah. No, that's not an answer. The answer is swallowing is the esophageal movement, peristaltic movement of esophageal, opening upper esophageal, closing lower, and opening lower. That's its end. That's the end. And deglutition is a coordinated swallowing and respiration. So what is the duration of swallowing in a newborn baby? Yalla ya Ahmed, if you know the answer. Yalla ya Ahmed.
Duration of swallowing?
Yes.
Yeah, I don't know.
Give me 1 minute, please. Hi, Dr. Marwa. Alaikum assalam. I'm online, so go quickly. How much now, the sugar? Okay, so start 0.01 unit per kg per hour. Okay, thank you. Yeah, 50% of TFI, so 150, give him 75 ml of fluid, D10 with electrolyte, sodium, potassium, and calcium, and ad-lib demand feeding without weaning. Clear? Don't do the same mistake last time. Okay, thank you. No need. We know the diagnosis. Do CBC, start antibiotics to prevent infection from other babies. So do CBC blood culture and start antibiotics. 48 hours. And blood culture, please. Electrolyte and bilirubin, total and direct. No, there is nothing called only total. Huh? And we need CBC too. شكرا. يلا يا دكتور عندي online. خلاص. Thank you. Okay. So what was the question?
We were talking
about
the
duration. Yeah, what is the duration of swallowing?
1 second, 1 to 2 seconds.
1 to 2 seconds. My goodness, if that 1 to 2 seconds, the baby will. How many times you breathe per minute?
The neonate
40
60.
to 60. 40
yes.
to 60, right? No, below above 60 abnormal. So 40 to 60, right? So if it's 60, that's meaning 1 breath every second, right?
Yes.
And what's the duration of 1 breath cycle? Yalla ya Ahmed.
Duration of 1 breath cycle?
Yeah, 0.38 second. 0.38 second, 0.37, 0.36, something like that. Depend on the maybe 0.4 in the term baby, 0.4 seconds. So remaining is what? 0.63. Yeah. Okay. 0.63. So that's the time where the baby can.
Less than 1 second. Yeah.
Less than. So the baby has to breathe during that period.
Okay.
That's what where is the coordination appear. Okay. Okay. Fetal nutrition. So you need the weight, the height, the head circumference, the mid arm fetal fat thickness, gluteal regions, also the cheeks. So when the baby is 24 hours, usually they have cheeks. And when I start to see the cheeks, I start to be very happy because, they're very nice. You can look at the Wharton jelly. If diabetes, it will be very big. If it's malnutrition, you will see only the skin and the blood vessels. You don't see Wharton jelly. So very important to look at the Wharton jelly and the subcutaneous tissue. You see that when babies are chubby or infant of diabetic mother, their faces feature cannot take the face. The face is smaller than the feature. So مجعوس يطلع مجعوس, huh? So very important to that. Respiratory fetal effort, very important too. And this is where the questions will come because most people think they know and they don't know. So paradoxical breathing movement is normal in newborn babies where there is the movement of chest, abdomen outward while the chest inward. So paradoxical movement between the chest and abdomen. There is also respiratory distress, such as pulmonary disease, include rapid breathing, nasal freezing, flaring, or use of accessory muscles, subcostal, intercostal, supracan, suprasternal, grunting. Then you need to count the respiratory rate, okay? So what is the respiratory rate? It should be less than 60. What is nasal flaring? Anybody knows? So it's movement, elinasi, outward movement, okay? Use of accessory muscle, significant subcostal. So I want to ask, anybody knows what is grunting? Grunting.
So the grunting is
يعني
expiratory movement against partial obstruction of epiglottis.
That's the way it is done. But what is it? And why is there? And what is the meaning? Because people thinking grunting is breathing difficulty. Do you believe like that, Muhammad?
Expiratory sound. Expiratory
no, wait,
sound.
wait, Muhammad. It's not a respiratory sound. Do you think that grunting is a respiratory difficulty or not?
Yes.
Yes or not, ya Muhammad?
Yes.
Okay. Anybody else think that grunting is a respiratory difficulty? Okay. So if you don't think it's a respiratory,
abnormal sound during labor,
it is not. It is not abnormal sound. There is no sound in grunting. That is mooning. Mooning يعني واحد شو اسمه ينوح. You are mooning. ينوح. الصوت هذا mooning is not a grunting. So if you don't believe like Ahmed, grunting is breathing difficulty. So what is grunting? So either you know or you don't know. Anybody knows? Not only you, even a pediatrician, they think
the baby need high pressure to keep airway open. So we hear this sound.
There is no sound in grunting, sir. Never. There is no sound. Sound is mooning, sir. It's a different story.
Okay.
Anybody knows what is grunting?
Grunting is a protective mechanism to prevent.
Yeah, but what is it? What is it? I know Taha is a man, and he's tall, and his weight is. I know that, but what is it?
Grunting is reverse of respiratory cycle.
It is reverse of respiratory cycle, sir. I think she read it from here. So what is it? Who is that? Shayma. What is reverse of respiratory cycle? يلا يا شيماء شو ورطك؟ What is the reverse of respiratory cycle? So Shayma, normally I breathe like you. Hey, like this. I take a breath, I exhale, and then I rest. After I exhale, I breathe in, I breathe out, then I exhale. If I am dog, I cannot do that. You know why? If I am pigs, I cannot do that. Why? You know why? Because Allah subhanahu wa ta'ala give us surfactant. Our alveoli will never stick. So we exhale out and we empty our alveoli and they will never stick because you have fat, you have surfactant. Okay? So when you lose surfactant, what you will do? You want to prevent alveoli from sticking. So what do? You exhale, and then you inhale, and then you rest when you are inhale. Well, normally you breathe like this. You pause after exhalation, while in grunting, you pause after inhalation. How you do that? You breathe in and you close your rhinoglottis. You close your lung. Okay, so you close it against the close pressure.
Expiration.
Yeah, so grunting means no surfactant. Grunting means deficiency of surfactant.
Okay.
So once you say grunting, in the court, they mean RDS. If you say grunting and you didn't give surfactant, they take you to the court. The lawyers know that, and most of the doctors don't know that. Yeah, very, very strange. So grunting means surfactant deficiency. It can be RDS, it can be adult respiratory distress. Grunting is not breathing difficulty. Breathing difficulty means flaring of elinasi, suprasternal, intercostal, subcostal recession, head nodding, okay, increased respiratory rate. Mooning is making sound. That's mooning. That's not grunting, sir. Grunting is reverse of respiratory cycle. Okay.
So if you want to define what we say about grunting, you know, if it's not
reverse of respiratory cycle. Pause after inhalation.
Okay.
Keeping PEEP up inside during exhalation by creating pressure against closed vocal cord.
Okay.
To prevent stickiness due to deficiency or absence or neutralizations of surfactants, such as in RDS or adult respiratory or during wound or during inhalation of any smoke. Clear? Yes?
Clear.
No?
It's clear.
Okay. So
Clear.
then I will ask, what is upper airway? Anybody knows? What is upper airway? Anybody?
عفوا أستاذ.
Go ahead.
Nose
Mustafa.
and mouth.
Nose and mouth is upper airway. Okay. Anybody else?
Nose and mouth, larynx,
larynx? And
yes,
trachea.
trachea and main bronchi.
And main bronchi. That's upper airway. That's
Yes.
Mustafa, right?
Yes.
Anybody else?
We can
I think
define the region
from Karina and
between,
above.
between
So
the
above
palate and
above
the hyoid.
carina, above carina, Taha يقول above carina is upper airway. Below carina is lower airway. Okay. What about Ahmed?
Well, anatomically, we can say it's the region between the palate and the hyoid bone.
It's between the palate and hyoid bone. Only Ahmed and Taha and anybody else? Nobody else here? You have to speak up. We are only three. Shayma, Bara, Muhammad, Thamir, Sudad, Zainab.
Hypopharynx والoropharynx to the region of the
Okay,
hyoid bone.
so I'm going to define it because it seems nobody knows what is, and not only you, by the way, even special, and even neonatologists, sometimes they don't know. So don't be surprised, don't be disappointed. So upper airway is the area of the airways that is surrounded by positive pressure. Lower airway is the airways that's surrounded by negative pressure. So any part of the airway within the pleura, within the thoracic, is lower airway. And this is movable. There is no anatomical position called upper airway. So upper airway is the part of airway that is surrounded by positive pressure, the atmospheric pressure, while the lower airway is the airway that is surrounded by negative pressure, the thoracic between the visceral and parietal pleura. Clear?
Clear.
And
Clear.
this is very important. Why? I will show you now why it's very important. So as you know that air moves because of pressure difference. So to move from point A to point B, you need the point A to be higher than point B.
Higher
so the
than
pressure
point
move.
B.
Because A is outside and B inside, and so the outside is higher than the inside, so the pressure will press on the airways and it will collapse it. So that's mean that the upper airway will collapse during inspiration. Clear?
Clear.
So the upper airway, this is the thoracic inlet, as you see. The upper airway, the lowest diameter during inspiration. While to move, again, any air to move from one point to another, it has to be higher. So point B should be higher than A to move outside during expiration. And that's why the outside will pull out because it's lower, and the inside is higher, will push out. So the diameter will be the highest during expiration. So then the airway, the lowest diameter during inspiration, and the highest diameter during expiration. Clear?
Highest diameter for the chest
Upper
wall?
airway.
For the
Upper airway.
Okay.
Upper airway. Highest, then we're talking about upper airway. So the highest diameter, largest diameter during expiration, while the smallest diameter during inspiration. Expiration and inspiration. For the lower airway, again, to move from point A, B to C, point B should be higher than C. Okay? So how we make point C lower? By moving the chest out, creating negative pressure. Because we create negative pressure, so you pull the lower airway out. And that's why the lower airway, the highest diameter during inspiration. While when we move out, this C has to be higher than B. So the chest compress to move the air out. And that's why the lowest diameter of the lower airway is during expiration. Clear?
Clear.
And that's why upper airway presentation will present during inspiration first, and the lower airway disease will present during expiration. And that's why pneumonia, bronchiolitis, asthma present mainly expiratory, while stridor, tonsillitis, epiglottitis, paravertebral abscess, quinsy, all present, trauma, all present during inspiration. Correct? Adenoid?
Correct.
Yes.
Okay.
Correct.
Do we understand the difference between upper and lower airway?
Yes.
Don't forget. Okay. No. And then, do you want me to stop now and complete next session? Because I think I took a long time. So I will stop at this and then we'll continue next session. So let me stop sharing. And I think, is my base okay? I am fast or slow? Do you like the session, or do you find it too easy or too difficult?
شكرا أستاذ، كان طريقة سهلة ومبسطة ومفهومة.
Okay, thank you very much. Okay.
Thank you.
Any more comments?
Thank you so much, Ustad.
الله يحفظكم. أنا مو أستاذ، طبيب عادي يعني ما يحتاج تقول لي أستاذ، قول لي يحيى أبو سيد.
السلام عليكم دكتور يحيى.
حبيبي دكتور محمد، كيف الله يحفظك؟ الله يبارك. اشتقت لك الصحة والعافية، الله يحفظك.
تعبيك ويانا، الله يبارك فيك.
لا بالعكس بالعكس.
الله
خير العلم زكاته.
الله يحفظك، بارك الله فيك، تسلم.
الله يبارك فيك. لا بالعكس، أحب أخدم أنا.
شلونكم زينين إن شاء الله؟
أنا بخير الحمد لله.
الله يحفظكم ويبارك.
الله يبارك فيك. Any question, any comment, anything you need. So once we finish with the newborn assessment, we'll do newborn documentation, and then we'll do a newborn resuscitations. Once we finish that, we'll do care of sick child. When the child crash in front of you, what you will do. And you will do it in very simple, systematic way. But the care of sick child is 400 slides, so it needs 10 sessions. Assessment of a newborn need about 4 sessions. Okay, because most of people think it's a simple things to do, and that's why they get caught in the court. Any question? الله يحفظكم. Any comment? No questions?
العفو دكتور يحيى، بالنسبة للسبسز يعني in general يعني إذا الهوسبيتال يعني blood culture not available يعني in the hospital. يعني بعض الأحيان نعتمد الكرايتيريا مال CBC يعني complete blood count. هل هو أكونيتروبينيا أو ليكوبينيا؟ بعض الأحيان هو طبعا نون سبيسيفيك صراحة. تعرف الفاسيلتيز يعني بعض الأحيان يطلع رونج أو كونتامينيتد كولكشن يكون مو يعني نوت كوريكت. تعرف هاي مهمة، how to collect the blood culture, how to incubate the culture. كل هاي المفروض يكون المختبر هم يكون بمستوى يعني عالي من الكفاءة بحيث يقدم خدمة بصورة صحيحة يعني، ولا يصير مشكلة يعني. فإحنا يعني بعض الأحيان نواجه هاي المشكلة صراحة بالعراق كله يعني يعني من الشمال إلى الجنوب.
نعم.
فاحنا بعض الاحيان اكو عندنا كرايتيريا مثلا ليكوبينيا كلينيكال مثل ما تفضلت، وبعض الاحيان عندنا هاي السيرياكتيف بروتين او البرو كالسيتونين يكون سبيسيفيك فور بكتيريال انفكشن. فانت رايك بالامور هاي تتوجه
واحده شو انا رحت 45 يوم في مركز اسمه هيفار cardiac center. Okay, in that center in Erbil, all babies they operate on below 1 year they die. Okay, so and then Dr. Zuhair invited me to see how you can improve and what. So first thing I said, what is the blood culture? Where is the blood culture? So they say we don't do, and I've asked why. They said we don't have. Okay, like you. So first thing I said, let's go to the lab. So we went to the lab. Okay. So I asked him why we don't have blood culture. It's very simple and very cheap. It's very simple and then cheap, and you can order it from Amazon. He said, no, doctor, we have it, but nobody ordered it. And then they got expired and nobody using it.
Yes.
والله الدكتور محمد والله ما بكذب يعني.
لا صحيح، لا مثل ما تفضل. وحتى العفو دكتور يحيى، اكو هاي الجديده البلاد كلتشر يسموه بكتيك تايب اوف بلاد كلتشر، هذا حتى اذا نستخدم انتيبايوتيك يعني نقدر نحصل على ريزلت من خلاله. حتى
الحين البلاد كلتشر از اوتوماتيك، الجهاز هو موجود، هو يقرا لك وتسوي له سكان، هو موجود يعني، هو از نوت اكسبنسيف. if there is no blood culture you have to go to the lab and check why. Now you have collection, you have size, and you have sterility, and then incubation and somebody reading it. So these are the steps of blood culture. So if you have no blood culture, please work on it. Without blood culture, there is no pediatrics. There is no pediatrics without blood culture. Now we also said about the inflammatory markers. So we have CRP, we have ESR, we have procalcitonin. Now I know many people depend on it, even here in UAE. I don't. So I will tell you that in my unit in an ICU, in PICU I used it. In an ICU, in last 2 years I never sent any inflammatory markers because they are very confusing. There are lots of variabilities, and leukocytosis, white PC, I mean CBC is very important. So for me, anything more than 15,000 in a newborn period is significant. Less than 5,000 is significant. So in both, I don't stop antibiotics. I continue for 5 days. I know sometimes leukocytosis up to 30 is normal in newborn babies, but it just, I name it rule out sepsis. So, and the sepsis are two types, early neonatal sepsis and late neonatal sepsis. Early neonatal sepsis, 70% is from the mother, it's E. coli. It can also be GPS, then E. coli, and it can be gram-negative, such as Klebsiella, Serratia, others. Late onset sepsis is mainly cones, coagulase negative, and Staph aureus, MRSA or MERSA. And late onset sepsis more localized. So you get meningitis, you get pneumonia, you get UTI, you get osteomyelitis, arthritis. Early neonatal sepsis is more systemic and is non-specific. Early neonatal sepsis, it depends on where do you work. Most people use date number 7, day 7 to differentiate, but some neutralists, or these are extremists, and some of the neutrals, they use day 3, and some other extremists on the other side, they use day 1. I use day 7 to differentiate because the treatment is different. So without blood culture, there is fundamentals of NICU and PICU. Blood culture, 1.
What about immature to mature neutrophils?
Yes. So we use the IT ratio. Yeah, I depend on it. If it's more than 0.2, more than 0.2 is a significant, and less than 0.2 is significant. So if the culture is negative and the IT is less than 0.2 or more than 0.2, I go 5 days. And baby is symptomatic and has risk factors. So baby symptomatic and risk factors, and there is leukocytosis or leukopenia or IT ratio, as you said, I go. I do not depend on inflammatory markers. I have very nice lecture presentation about antibiotics in pediatrics and how to use antibiotics in an ICU and antibiotics in PICU. So I have three nice lectures. I've worked on it a long time. I can present it at some point to the group.
Thank you very much for this information.
Thank you, Dr. By the way, Dr. Muhammad, he was my senior, if you guys don't know. So I was junior resident and he was my senior resident. Right, Dr. Muhammad?
Yes, thank you.
بس قبل 25 سنة أو 27 سنة يعني.
صحيح صحيح.
Any question from the group?
يبارك.
Don't feel, الله يحفظكم. Don't feel shy. Just ask question, even if it's if you think it's a silly question, please ask. There is no silly question, most people. But in the presentation, I ask question because I know you don't know. I mean, I know because it will stick into your memory when I do it in this way. So if you guys don't have question, I can end the session and it's recorded. I will pause the
العفو أستاذ. بالنسبة للنيوناتال مننجايتس.
Yes.
اكو رول للكورتيكوستيرويد بالمانجمنت اوف neonatal meningitis.
Yes, depend on the bacteria. Yes, there is a role for steroid. But the steroid in neonatal period is very serious medication. So you have to use it with a documented benefit. If it's not documented, there is something called aboptosis. Have you heard about aboptosis?
No.
Aboptosis is a programmed cell death. Aboptosis, prenatal.
Of the brain?
No, all the cells, all the body, mainly the brain, any active cell, including bone marrow, or so mainly the memory cell, the liver, the bone, but mainly is the brain. So aboptosis is protected by the mother. Once the baby born, the aboptosis will start. So the steroid fasten that. So to use steroid, it's very important that parents should sign because there will be a problem in the neurodevelopmental outcome at 24 by Bailey assessment. So using steroid is very serious. And I know some people using steroid in Iraq in RDS. This is absolutely wrong. If you do it in outside Iraq, your license will be removed and you will be maybe prevented from practicing pediatric. It's absolute crime to give steroid for RDS, because RDS is a temporary problem. You just need CPAP, ventilation, and surfactant. And after 48 hours guns, while steroid has permanent effect. So steroid only in documented benefit in certain bacteria, not all the bacteria. And it has to be started before starting antibiotics to prevent the endotoxin causing inflammation and damage to the brain more than the aboptosis. And that's why whenever you
عفوا استاذ يعني احنا اول وتالي راح نرجع على نقطة الكلتشر.
Yes, of course. Without culture, no practice, no pediatric.
Yeah.
Culture is more important than nurse. Culture is more important than nurse, more important than the doctor, more important than food.
Yes.
Culture is important, and it is not there, it's there. And if we need a session on how to do the blood culture, we can work with the lab, we can want. Without culture, there is no NICU, there is no PICU. Culture is vital. No antibiotics without culture. And we have to prevent, I work in a clinic for 2 months, for example. I only use one time amoxicillin for 2 months. And I see 10 to 20 patients per day. One time, no antibiotics outside. Antibiotics is very dangerous. Is one of the documented risk factor for neck necrotizing is antibiotics use. And one of the documented is mother milk use. So the most important prevention of neck is not only that, antibiotics reprogram the biome of the body. So you keep suffering from all your life. You get colon problem, you get probably inflammatory problem, you get migraines. You reprogram your body when you use antibiotics. So antibiotics has to be used in a documented way. very
يعني
dangerous to use antibiotics.
يعني نرجع بالنقطة اللي هي إذا كان أكو sign risk factor and sign symptom with negative culture، بهاي الحالة إحنا ما ننطي ستيرويد، ما نستخدم نهائيا الستيرويد إلا في حالة إذا أكو culture positive وينطينا نوع البكتيريا.
Yes. Because the steroid effect on the brain is very dangerous. So the benefit has to be more than the effect, which is presence of endotoxin that cause damage to the cell of the brain.
Yes, yes.
And I can provide you with the list of the bacteria that steroid, and it has to be done before. So what we do, we suspect that bacteria, we start steroid, and if the culture is positive after 48 hours, we continue, depend on the course. And if it's negative, we stop the steroid.
Okay, so which age we can use steroid safely in pediatric?
I'm working in neonatology now almost 17 years. I use steroid for sepsis maybe 2 or 3 times in my life.
Okay.
Very rare, very rarely I use steroid. Very rarely.
No, I meant the age. Like 3 months, 4 months. We can give the steroid safely.
The later, the better. The later, the better.
The later, the better. Okay.
Yeah, the later, the better. So you need to avoid it. It's very important to avoid it. The steroid, okay. Especially first week of life. Very important.
Even for a few days, like 3 days.
Yeah, I don't know the effect of a few days on the neurodevelopmental outcome, but the longer, the more effect. The shorter, the less effect. So, but I am not sure exactly. I don't have number to say how many days that steroid. But steroid need to be avoided, and the parent has to sign a document. So we have a document about steroid. So we explain to them, and they sign. And if they refuse, they have to sign LAMA. So against medical advice. And without signing LAMA, any lawyer can take you to the court, and then he'll ask for compensation if the baby has teaching difficulty or mathematica or learning disability or neurodevelopmental outcome, loss of urine control, bowel control, or any domain of development, whether motors or sensory or social or cognitive. Okay. Questions?
العفو أستاذ، بالنسبة للنيوناتال مننجايتس إذا كانت جرام نيجاتيف 21 days antibiotic.
It depends on the bacteria. On the bacteria. So minimum, if it's Klebsiella pneumonia, for example, minimum 21 days and 2 culture negative. So what we start antibiotics, and then every 48 hours, we repeat the culture. Every 40 hours, we repeat the culture. So you have to give minimum 21 days of the sensitive antibiotics. Because remember, antigun bacteria, there will be sensitivity. So the sensitive antibiotics, from the day of start, 21 days, plus 2 cultures, 48 hours apart. Negative, then you can stop.
What about LB, lumbar puncture? Culture of CSF. We have
culture
to
do
of
CSF, and blood culture negative or positive?
If negative.
Blood culture negative, so you have meningitis, but you don't have bacteremia. Right?
Yes. No.
And you can have sepsis without meningitis, and you can have both. Okay?
If I have meningitis, yani I do LB, and the LB was positive with high cells.
No, that means nothing. CSF culture.
Yes, CSF culture was positive with
positive
E. coli.
Which bacteria? E. coli. E. coli, yes. 14 days. And 2 culture negative 48 hours apart.
2 culture of blood?
2 culture of blood, yes.
Yes.
And the CSF, of course. So you have 2 cultures negative and 2 culture CSF.
2 culture CSF negative.
Yes, so you
and
keep repeat. Yes, you keep repeat the CSF every 2 days, a culture until it's negative.
And if we have 2 negative culture after 14 days, we continue 21 for gram negative.
Yeah, 21 days plus 2 culture negative 48 hours.
Yes, you said we should continue 21 days.
21 days plus 21 days plus 2 culture negative 48 hours apart.
And these 2 cultures after the 21 days? Or
no,
before?
You start blood culture, you have
Yes.
culture A positive.
Okay.
After 48 hours, you repeat it. After 48 hours, as far as positive, you keep repeating it.
We keep
Every
repeating
48
it
hours.
every
Yes.
2 days. Okay.
Every 2 days until you have 2 culture negative. So you get first condition, 2 culture negative. And then you should have 21 days of antibiotics.
So we continue the treatment in spite of the negative blood culture.
21 days for Klebsiella pneumonia, 14
Yes.
days for E. coli.
Okay.
If you have osteomyelitis, 6 weeks. If you have arthritis, I think it's 3 months.
Okay.
And 2 culture negative. The blood
Two
and the
culture negative.
synovial fluid. You got it? So it depends on where you
Yes.
are. But today is not about sepsis. Why are you guys asking about sepsis? Ask about assessment. The topic was assessment, not sepsis.
By the way, يعني
Yes. Are you talking to me?
no.
Okay.
By the way, we ask about sepsis, but
Oh, by the way, no, we can do a topic. We can do a separate topic about sepsis in detail.
Tamam.
Simple tricks people don't know, because people read, they think they know, they don't practice. So yeah, we have sepsis about, and we can use also antibiotics in pediatrics. So how to use antibiotics and when and how and what and how you select, because people think they know. And proper dose, people think that they never give antibiotics without reading the dose before you give it. Don't give antibiotics ever without reading the dose prior to that. Because the dose, if you do it from your brain, the dose is wrong. Like 70 to 80%, the dose is wrong. The duration is wrong. The frequency is wrong. Okay. Because, for example, people, they don't know the difference between erythromycin succinate and erythromycin oxalate. They think they are the same, but the doses are different. Okay. So you have to know, you have to read and have a reference how to give it. So I never give antibiotics at this age and after this experience without reading the dose, even a gentamicin. I read the dose, the frequency, the duration. And when I get the bacteria, I go read about it. What is the duration? What is N? What is the dose? What is the maximum? What is the side effect? And then I plan the treatment and so on. More question on assessment, not on sepsis. Okay. So we'll see you next session. I will post the video in the group. Thank you very much for attending. Assalamu alaikum.
Thank you.